Hello.
So, do you transfuse? It's a question we face constantly in the ICU, and a brand new 2025 CHEST guideline is set to significantly change how we answer it. In this explainer, we're going to break down exactly what these updated recommendations for platelet and FFP transfusions mean for your critical care practice. I'm Dr. Mech, and this is the Dr. Mech Explainer series, where our goal is to distill complex guidelines into clear, actionable insights. And a quick disclaimer, this content is for informational purposes only and does not constitute medical advice.
The information we're covering is taken from the following source.
Right from the start, the guideline sets a powerful tone. It's telling us to be more restrictive. The key takeaway here is that for the vast majority of our critically ill patients, the known risks of transfusion just don't stack up against the very limited and often unproven benefits. Our new default mindset then should be to avoid transfusion unless it's absolutely necessary.
All right, let's start with the foundational thresholds. This is our baseline. What to do when we're not planning an immediate procedure.
Okay, so for your stable, non-bleeding patients at low risk, the new suggested trigger for a prophylactic transfusion is a platelet count below 10,000. Now, what's really important to understand is that this is a conditional recommendation. And you'll see this theme throughout. It's based on very low certainty evidence, which is why our clinical judgment remains absolutely key.
Now, what about our high-risk patients? These are still stable, non-bleeding individuals, but they have other factors that make us worry about spontaneous hemorrhage. Here, the guideline suggests a higher threshold, somewhere in the range of less than 30 to 50,000. The challenge, of course, is that high risk isn't some black and white definition. This is where we have to use our judgment, thinking about things like sepsis, DIC, or maybe a tumor in a dangerous location.
And then, of course, we have the patient with serious active bleeding. In this scenario, the recommendation is to transfuse to maintain a platelet count above 50,000. This is pretty much in line with standard practice. When someone is hemorrhaging, our top priority is achieving hemostasis. So what exactly does the guideline mean by serious bleeding? Well, they anchor it to the WHO bleeding scale, specifically grades 3 and 4. We're talking about bleeding that's significant enough to require an RBC transfusion, causes hemodynamic instability, or involves the central nervous system. Making this distinction is critical for applying the correct threshold.
Okay, now we're moving on to prophylaxis from most procedures. This is really the heart of the guideline and where you'll see this restrictive approach play out in our day-to-day work. This is a big change. For placing a central line or an arterial line in a patient with a platelet count between 10 and 50,000, the recommendation is to suggest against routine transfusion. The same goes for FFP. Why? Because the data just doesn't support it. Major bleeding is very rare with these procedures, and giving blood products beforehand doesn't seem to make a difference.
And that same restrictive thinking applies to other common bedside procedures, like a thoracentesis or paracentesis. Again, the guideline suggests against routine prophylactic transfusion of either platelets or FFP. The rationale is the same. These are low-risk procedures, major bleeding is rare, and there's no clear evidence that transfusing helps.
This pattern holds true even for diagnostic endoscopies without biopsy. The guideline suggests against transfusion here too. In fact, some data, particularly in varicose bleeds, hints that prophylactic transfusions might even be associated with worse outcomes. While this is likely a marker of patient acuity, it certainly doesn't support giving blood products routinely.
You are watching the Dr. Mech Explainer series. So we've just seen this clear pattern of withholding transfusions, but now we come to the one critical exception to that rule, the lumbar puncture.
For an LP, the guideline does a complete 180. It suggests transfusing platelets if the count is 40 to 50,000 or less, and giving FFP to target an INR somewhere between 1.5 and 2.0. The reasoning is simple: risk versus benefit. A spinal hematoma is rare, yes, but the neurological consequences are absolutely devastating and often irreversible. So the potential for harm is just too great to ignore.
So, let's talk about the broader impact and how we can actually implement these changes in our units.
Putting all of this into practice isn't just about one clinician changing their habits. Because these are conditional recommendations, it really starts with shared decision-making. We also need unified institutional policies to get everyone on the same page. This will not only reduce costs, but critically, it will also improve equity and access to these precious resources for the patients who truly need them. And the scale of this potential impact is, well, it's huge. The authors estimate that if these guidelines are adopted widely across the U.S.,
we could avoid something like 500,000 unnecessary platelet and FFP transfusions every single year. That's a massive step forward in resource stewardship.
You are watching the Dr. Mac Explainer series.
Guidelines like these are exactly why it's so important to stay current with the evidence. To make sure you don't miss future updates, please subscribe to the Dr. MEK Explainer series and be sure to activate your notifications.
So there you have it. This is a major shift toward a more restrictive, evidence-based approach to transfusion. And that leaves us with a final question to reflect on. How will these new recommendations change the way you manage transfusions in your ICU?